So I'm going to talk to you a little bit about imaging in neuroendocrine tumours today. And probably this is going to seem like a little bit of a sales pitch for functional imaging or PET-CT, and I'm pretty sure that none of you need that sales pitch, but it is one of the things that we do which is different to run-of-the-mill imaging, makes a huge difference in neuroendocrine tumours as well as other kinds of tumours, and is an area that I'm particularly interested in. So as we know, neuroendocrine tumours are a really variable, really heterogeneous group of tumours. We have everything from the very low-grade indolent tumours, which can often produce the clinical hormone-driven syndromes that Chris was mentioning, up to the poorly differentiated tumours, which can lack that hormone syndrome but can be aggressive and grow quickly. Interestingly, both of these kinds of tumours, the entire grade, have the potential to metastasize or spread throughout the body. So while they're a very variable group of tumours, what they do have in common are several biological properties, including the presence of something called a somatostatin receptor on the cell surface in the majority of these tumours. Somatostatin is a hormone which binds onto these receptors, kind of like a lock and a key, and somatostatin regulates processes of the cell, such as cell proliferation or growth and hormone secretion. And it provides a specific molecular target which we can use for both imaging and treatment. So when we talk about conventional imaging, we're really talking about these three modalities: ultrasound, CT, and MRI. Ultrasound is often the first imaging modality, first experience with radiology that patients will discover in their journey. And that may be, they may be referred for an ultrasound because of their symptoms, such as abdominal pain or non-specific abdominal symptoms or symptoms of unwellness. Ultrasound is good for looking at the solid organs in the abdomen, so things like the liver and the kidneys, the spleen and the pancreas. It's not great for looking at the bowel, which is obviously one of the common sites of neuroendocrine tumours. Later on, ultrasound can have a role in guiding biopsy. So often we reach the diagnosis of a neuroendocrine tumour by a slightly roundabout route, in that we may discover tumour that has spread or metastasized, and we end up biopsying that. And ultrasound is very good at guiding biopsy of the liver, for example. CT is really the workhorse of oncology imaging, including neuroendocrine tumours. CT may be performed for investigation of symptoms again, or often these days people have a neuroendocrine tumour suggested first on a CT which is performed for some other reason. It might be a trauma or an unrelated symptom that leads to a CT and then has a finding which leads to the suggestion of a neuroendocrine tumour. On a day-to-day basis, once the diagnosis is made, we use CT commonly for staging, which is what we call defining the extent of disease prior to treatment, and restaging, which is when we reassess what the disease status is on CT. And CT also has a key role in defining the anatomy if we're considering surgery. It's got some advantages in that it's readily available all throughout the country, it's quick and it's easy. The disadvantages include that it may involve ionizing radiation, and that's something that we do consider in, for example, young patients in the follow-up period if they've had disease surgically removed entirely. It also has some limitations in that it doesn't give us functional information. It doesn't tell us what receptors are being expressed on the cells of these tumours, so it doesn't give us avenues for treatment in that way. Also, size of lesions doesn't always correlate with the activity of the lesions. And I'll show you a couple of examples later, but CT can be sensitive to various technical issues which can make interpretation of the findings difficult, particularly if you have less experience in reporting these. The third of the conventional imaging methods is MRI, and this is really what we use as a problem-solving tool. It's not an everyday thing, it's more expensive, it's less available, and it takes longer to perform. We often use this if we've found a liver lesion and we're trying to figure out exactly what that liver lesion is. And we can also use that to look at the amount of disease involving the liver, because MRI is actually the most sensitive method for looking at the amount of disease within the liver. When we talk about functional imaging, the original of the functional imaging methods for neuroendocrine tumours was something called an octreotide scan, which first became available in the 1980s. Octreotide is a synthetic somatostatin analogue, so it's a mimic of somatostatin, which binds to the somatostatin receptor on the cell surface of neuroendocrine tumour deposits. Basically, they take octreotide and they radiolabel or attach something called indium-111 and inject it. The octreotide binds to the cells in the body which express somatostatin receptors on their surface, and then the radioactive indium decays or breaks down, releasing small radioactive particles which the nuclear medicine cameras can pick up. And by doing this, they can get a distribution and amount of cancer cells that are distributed throughout the body. They can also identify where there is physiologic uptake. Physiologic uptake means normal uptake that we would see in a person who doesn't have a neuroendocrine tumour, because there are cells throughout the body which have these somatostatin receptors on their surface. That octreotide scan has largely been replaced by PET-CT, which is the new gold standard for imaging of neuroendocrine tumours. It's proven to be more accurate than conventional imaging, including octreotide, SPECT-CT, and contrast-enhanced CT. Rather than the indium-111, we use something called 68 gallium dotatate, sometimes called GAT8. The advantages of this are that it breaks down over a much shorter time period than the indium, so 68 minutes versus 3 days. What that means is that the injection is done and then we can scan about 45 minutes to 75 minutes later, as opposed to the old Octrea scan when you used to have to come back a day later and then 2 days later to have your scan after the injection. We also at the same time perform a diagnostic quality CT, which allows us to anatomically correlate any abnormalities that we see. So each study in a PET-CT produces thousands of images, which is why you might wonder why it takes so long to do a report, is that for a start we have to wait for the images to come through, and then literally each study will produce 2,000 images. And all of our studies are reported by a radiologist, and then they're double read by another radiologist to try and make sure that we're as accurate as possible. So we produce both PET images and CT images, and this allows us to create fused images, which gives us great anatomic correlation. So these images, just to clarify, are what we call a coronal image. So, sorry, just to clarify, the head, the chest here, and the abdomen, and we've got here uptake within the liver. This is the kidney, the other kidney. Here's the bladder, that's the spleen, and up here, this structure here is the thyroid gland. So these are all normal sites of uptake. So this normal uptake or background noise can create a potential pitfall, but it also provides us with a reference to judge abnormal or pathological uptake against. And this is a score that we call the Krenning score. And that's basically using the liver and the spleen as reference organs against which we judge the level of uptake within tumour deposits. And that's just a score from 0 to 4, as seen there. So like octreotide scans, somatostatin PET-CT or GAT8 PET-CT relies on the presence of those somatostatin receptors on tumour cells. And there's 5 main types, of which SSTR2 is the most commonly overexpressed in neuroendocrine tumours. And we use dotatate or GAT8 because it has the highest affinity for these receptors. We can use both the Krenning score and another score which is called the SUV max. Now that's a quantitative measure, that's a number that we get when we highlight an area on our scanner, and it gives us a number. The thing about that number is that you can't compare that number between different machines. So for example, many patients may have had their original scans done at Peter MacCallum Cancer Centre in Melbourne before we got our scanner in Auckland at Mercy. And while we can do a subjective comparison between those two, we can't compare those numerical values. You can only compare those numerical values for the same patient on the same scanner, which is why it's great when we have a patient having multiple scans on the same scanner over time, because we've got actual quantitative numerical comparisons between different scans. So I'm going to show you some pictures now, because this is what I like best, pretty pictures. Just about some of the ways that we use GAT8 PET-CT in neuroendocrine tumours. One of the first things that we can do is use GAT8 PET-CT to confirm diagnosis of a neuroendocrine tumour. This can be really valuable when we've got a CT appearance which says to us, hey, this looks like a neuroendocrine tumour, but it's in a spot that's very difficult to biopsy. For example, this patient presented actually for a CT colonography study because they had a change in bowel habit, which is why the colon here is all distended with gas, and so is some of the small bowel. Now that study didn't show any abnormality in the colon, but did show this here within the mesentery. So the mesentery is just the fatty area between the small bowel loops, and that's showing this soft tissue mass here, which has a bumpy, irregular margin and some calcification within it. And that's a really typical appearance for a mesenteric metastasis from a neuroendocrine small bowel tumour. We often don't see the small bowel tumour. They can be tiny. So sometimes we can see this kind of mesenteric mass, and we can't on CT find the small bowel tumour because they can only be 3 or 4 millimetres big. And when the bowel is all collapsed, there's no gas in the bowel normally on a normal CT scan, so you can't really tell the normal bowel wall from a tumour. In this case, the patient happened to have had gas from their colon, went backwards into their small bowel as part of this tumour, part of the study, and showed the small intestinal tumour here, adjacent to the mesenteric mass. But you can see when there's all of these bowel loops lying in front of that, that's going to be really difficult to biopsy without doing an operation, essentially, which is quite invasive. So we did a GAT8 PET-CT, which let us confirm that both the small bowel tumour here and the mesenteric deposit here both demonstrated uptake consistent with a neuroendocrine tumour. So you can see the sort of background level within the liver, and it's certainly more than that. But we would normally compare also to the spleen. The counterpoint to this is in excluding a neuroendocrine tumour. Sometimes we have an appearance on CT which looks like a neuroendocrine tumour, but again, it's going to be difficult to biopsy, and we want to know whether it is or not. In this case, a patient had a mass here in the mesentery again. It doesn't look entirely typical, but you can see it's got a lot of similarities to the case I showed you just before. So we recommended they have a GAT8 PET-CT, which showed, you can see on the fused image there, that there's no uptake within that mass. They went forward to have a biopsy, and that actually yielded a diagnosis of a tumour called a leiomyosarcoma. We can also use GAT8 to localise or to identify a primary tumour in a patient who we think has a neuroendocrine tumour because of particular symptoms and biochemical or blood tests which suggest that they have a tumour, but we can't find one on conventional imaging. Particularly pancreatic tumours can be very, very small when they produce a very typical clinical syndrome, and we can't see them at conventional imaging, but GAT8 can help us to localise them. This patient had had resection of a neuroendocrine tumour from the pancreatic tail and then presented with recurrence of symptoms. We did a CT, we did an MRI, and we couldn't find any abnormality within the pancreas. But then we did a GAT8 PET CT, which showed us this tiny focus of uptake within their region of their pancreatic head. And that let us correlate with the CT and identify, in retrospect, a very subtle tumour within the pancreatic head. Patients who present with biopsy-proven neuroendocrine tumour at sites of distant metastatic disease may also not have a primary lesion identified on conventional imaging. And identifying this primary tumour can really assist in determining both prognosis and selection of therapy. This patient presented with abdominal pain, and CT showed a liver metastasis. Biopsy demonstrated that this was from a neuroendocrine tumour, but we couldn't find a pancreatic or small bowel tumour. GAT8 PET CT confirmed that the liver metastasis was likely of neuroendocrine origin, and it let us find this focus within the small bowel, which was the primary tumour. And even on retrospect, looking back at the CT, we couldn't see that on CT. Another advantage of functional imaging is identifying multifocal disease, as Chris outlined. It's not an uncommon occurrence. Up to 30% of small intestinal neuroendocrine tumours are multifocal. And also a subset of neuroendocrine tumours occur in the setting of a genetic syndrome like MEN, which can predispose to multiple tumours. This patient had a mesenteric mass and a small intestinal tumour, which looked typical for a neuroendocrine tumour. GAT8 PET CT confirmed that these findings demonstrated uptake, but also demonstrated an unexpected second small intestinal neuroendocrine tumour, which we could then localise on CT. But you can see how subtle that finding is. This patient had a pancreatic tail neuroendocrine tumour, which demonstrated marked uptake greater than the adjacent spleen. But our GAT8 PET CT also demonstrated a second tiny little focus there, about the big as my pointed dot there, which we could then localise on CT. As you all know, defining the extent of metastatic disease has a huge impact on prognosis and treatment selection, and multiple studies have demonstrated the high impact of functional imaging on management. This patient had a previously resected pancreatic neuroendocrine tumour and presented for restaging after progression on CT. GAT8 PET CT clearly shows extensive liver metastases. You can see here multiple areas of uptake within the liver. And this had not really been, the extent of this wasn't really expected on CT. As you can see, this is a portal venous CT, so this is one of the phases of CT imaging that we do. Shows only a small area of abnormality within the right lobe of the liver and really underestimates the volume of metastatic disease. Another real advantage or real strength of functional imaging over conventional imaging in neuroendocrine tumours is in bone disease, which is often what we call CT occult, cannot be seen on CT. So this patient demonstrates uptake there within the right iliac bone, which is highly suspicious for metastasis, but a CT performed at the same time demonstrates no abnormality. This is a more subtle case where we had we had prior imaging on this patient, so we could see that this area of subtle uptake was a new finding in the left scapula or left shoulder blade. And a CT at the same time demonstrates no abnormality. Because this one was more subtle, we did an MRI, which confirmed that there was a metastasis within the left shoulder blade. As mentioned earlier, the localization of primary disease and the definition of the extent of metastatic disease helps guide both prognosis and treatment decisions. PET-CT in particular helps us to decide which patients are suitable and which are not suitable for different treatment pathways. For example, here's a patient with widespread metastatic disease, and the important fact here is that the metastatic disease is strongly GAT8 avid. So when we say strongly GAT8 avid, we mean it's taking up lots of the substance. It's got a high density of those somatostatin receptors. So there's lots of those receptors on the cell surfaces, which means that this patient is likely to respond well to a treatment which targets those receptors, like PRRT. And as I mentioned, we judged that against the spleen, so that's normal uptake in the spleen, and you can see that these uptakes in the bone here are all greater than that of spleen. That means they've got a lot of receptors. They're going to bind a lot of the radioactive particles if they have PRRT, and they'll probably respond well. In contrast, this patient had a neuroendocrine tumour with extensive liver disease and was being considered for PRRT. But GAT8 PET-CT shows that many of these liver lesions demonstrate less uptake than background liver and much less uptake than the spleen. This means that they've got a low density, a low number of receptors on the cell surfaces, and they're not going to respond well to PRRT. In fact, many of those lesions demonstrated increased uptake on another kind of PET-CT called an FDG PET-CT. That's basically, instead of targeting receptors on cell surfaces, an FDG PET-CT is basically a sugar scan. So we radiolabel a sugar molecule, and sugar molecules are taken up by cells which are turning over rapidly. So this shows that a cell that takes up a lot of the sugar molecule is either growing quickly, or it's not really expressing those cell surface markers of neuroendocrine tumours anymore. It's a little bit less organised, what we call loss of differentiation. As I mentioned, conventional imaging relies on a change in size of tumours or metastases to judge treatment. But we've found that that's often actually size is a poor surrogate for activity within a lesion. And the other factor I mentioned is that CT can be sensitive to technical factors such as the timing of post-contrast images, which can affect the sensitivity for detecting liver lesions in particular. This patient had a metastatic neuroendocrine tumour that originated in the large bowel. GAT8 PET-CT confirmed extensive disease, which was predominantly involving the bone, and indeed the major symptom in this patient was bone pain. The patient proceeded to PRRT, which yielded an excellent imaging and, more importantly, an excellent clinical response for the patient. So you can see on the left is the pre-treatment and on the right the post-treatment. And all those sites of uptake within the bone have basically been treated and become inactive. Here's a case I showed you earlier with lots of liver metastases on PET-CT and the plain CT at the time, which demonstrated little of the disease. The arterial phase performed at that time, which is a different phase of post-contrast imaging. So it's basically we give the contrast at CT and then we take some pictures early on in what we call the arterial phase, when all the contrast is sitting in the arteries. And then we take a picture a little bit later on in what's called the portal venous phase, where the contrast is sitting in the organs and the veins rather than the arteries. The reason I show this is that a lot of neuroendocrine tumours will produce primary or metastatic tumour deposits which enhance best in one phase or the other, and often it's in the arterial phase. That's because they've got a lot of blood supply, and so they light up basically in this phase rather than that phase. Also didn't show the disease particularly well, even though a CT performed a couple of weeks earlier had shown definite deposits of tumour. So this is just to basically highlight that CT can sometimes be tricky to interpret, and particularly if a scan's done a few seconds later or a few seconds earlier than another scan, it can create uncertainty about whether there actually has been disease progression or there hasn't been disease progression. So this hopefully can explain the fact that sometimes you might get mixed messages in your radiology reports, because it can sometimes be difficult to take these factors into account. And the great thing about the functional imaging is that it kind of removes that uncertainty. Like anything else though, there are pitfalls and there are limitations to PET-CT. As described earlier, we have the physiological uptake on PET-CT, which can muddy the waters a little bit. And this is just to show you one of the sites of physiologic uptake, which can be confusing sometimes. This uptake here, which looks very prominent, but is actually physiologic uptake within a portion of the pancreas called the uncinate process. But CT performed at the same time lets us also say that there's no anatomic abnormality to correlate to that, and knowledge of the normal appearance of this physiologic uptake lets us be sure that that's not an abnormality. There are also other lesions, for example, lesions within the bone that can take up the tracer and can show as hot on the PET-CT. There are inflammatory conditions such as prostatitis, sarcoidosis, or post-treatment changes. And importantly, there are other tumours such as meningiomas, which is a benign tumour within the brain, and lymphoma, which can take up some of the tracer and produce a hot spot. So sometimes as a patient you might have had a scan like this and then find that some other kind of imaging is suggested to confirm or further evaluate an abnormality, and that's just because none of our imaging modalities is perfect. Much as we'd like it, we don't get the answer printed out on a piece of paper when the scan's done, and there is a certain amount of art to interpreting these. Sometimes we like to be sure and use another kind of scan to confirm or deny something. Just to mention, many people will have known about or be on octreotide, which is basically a drug which binds to the somatostatin receptors and blocks their function. And that can help with the endocrine symptom that many patients with neuroendocrine tumours have. Administering these drugs, though, can change both the physiologic and the pathological uptake on functional imaging. So generally, we discontinue short-acting octreotide for 12 to 24 hours prior to doing a GAT8 PET-CT. And for those on long-acting octreotide, we usually perform the GAT8 PET-CT in the week prior to the next dose. So that's 3 to 4 weeks after their last dose. Small volume disease may be less accurately assessed on PET-CT, particularly in the liver, where MRI is much more sensitive than PET-CT. MRI can detect lesions down to about 2 millimetres, whereas PET-CT has a size cutoff around 4 to 6 millimetres. And as mentioned, poorly differentiated disease may stop expressing somatostatin receptors, and in these settings there's a complementary role for FDG PET-CT. Just a brief, as mentioned, FDG PET-CT can be useful in providing information on the cell turnover or rate of growth or aggressiveness of a tumour, and it's also important in identifying discordant disease, which is the term we use for disease which is not expressing the somatostatin receptors anymore, so it's GAT8 negative, but it's FDG positive, as these patients are unlikely to respond well to PRRT. It also gives us some prognostic information. Just to finish off, I'll just show you this slide, which is, I think, what a lot of people think of when they hear the term PET-CT. This is a dog that we scanned at Mercy, and because dogs get neuroendocrine tumours too. This patient was having investigation for an insulinoma, which is a pancreatic neuroendocrine tumour. But this is not what we're meaning when we ask you about having a PET-CT. So thank you very much for your patience. I know that there's a lot of terms there and a lot of jargon, which is very hard for us to avoid.